presented in the categories of advancing wellness, expanding the evidence, collaborative strategies, innovations in care, and measuring value. A sixth award will also be presented for our outstanding poster presentation. This will be the beginning of our Friday afternoon keynote, and I would really encourage you to join us so that you can help us recognize the outstanding leaders. We have an incredibly highly esteemed panel of judges who will be selecting our awardees this year. You'll see them in the front of the concurrent session rooms, and I hope that you'll join me in expressing your appreciation for their assistance in helping us identify this year's leaders. Another significant component to the conference this year is our expanded networking and solutions recognition. Yesterday, for the first time, we hosted a networking session for 150 members of our industry and leaders in our industry. We gave them 8 topics to choose from, and they divided into small groups to discuss these topics and to identify recommendations, challenges, and opportunities. My staff and I will be taking the feedback that we receive from each one of those groups and putting it back out to you so you can have the benefit of that discussion. And we look forward to continuing to evolve those types of networking sessions at future CCA events. Another incredible networking enhancement that we have developed for this year is the Networking and Solutions Zone. Thanks to all of you who joined us last night for our welcoming reception. We had a great event in the Networking and Solutions Zone downstairs in the lower level of the facility here. And I hope that you'll join us for our other networking events today and tomorrow. We've this year divided the Networking and Solutions Zone into 4 neighborhoods. And we did this to better highlight some of the core strategies of population health management. Some of the feedback that we received in our previous conferences was really about coming into the exhibit hall and going up and down the aisles and having a hard time finding the kind of solutions providers that someone might need for their own programs and their own populations. This year we've divided that into 4 different strategy zones, and I encourage you to spend some time in each zone with the different solutions providers. The neighborhoods are divided into destination wellness, the data marketplace, the virtual edge, and care strategies. And there are fun and interactive activities in each one, as well as some great food, so don't miss that. I'd finally like to thank and recognize our leadership for the Care Continuum Alliance. Our board chair, Chris Colloyan with Pretalytics, is serving his final days as the chair of our board of directors. Chris has been an incredible leader for this organization for the last 2 years, and I'm indebted to him for his leadership, and I hope that you'll join me in expressing your appreciation if you see him in the conference over the next couple of days. We had Chris as our leader yesterday, and we had an incredible discussion about continuing to expand our strategic leadership on behalf of this industry. On behalf of the board of directors and myself, I hope that you'll continue to provide us feedback so that we can continue to serve and lead on behalf of this industry. Thank you again for joining us. I want now to introduce our next speaker, Fred Goldstein. I've had the privilege of working with Fred over the last couple of years, and this past year he served as chair-elect for our board of directors. Tomorrow afternoon, Fred will assume the chair position for our board of directors and begin the service of his 2-year term. Fred brings to the Care Continuum Alliance board 25 years of executive leadership in disease management, managed care organizations, and hospitals. He is currently president of U.S. Preventive Medicine, where he previously served as Chief Government Affairs Officer, New Technology Officer, and Chief Operating Officer. It is my pleasure to welcome Fred Goldstein and to introduce you to him as your incoming board chair. Fred?
Well, after Tracy's intro, I was looking forward to Metallica, but I'll go with The Who. So I may look a little gray here, but we're all right. Thank you so much, Tracy. And good morning. I want to welcome and thank you all for attending this year's Forum 2012. I'm very excited by this opportunity to be here, and more importantly, the opportunity to meet with each of you during this conference. Also, I've been asked to point out, and please I shall here, there is an iPhone app, iPad app, and an Android app. If you haven't downloaded it, do it now. It's actually pretty interesting. The iPhone app in particular is excellent. It may sound cliche, but this really is an exciting time for our industry. During the past few years, many of us have not been immune to the economic pressures that have faced our country. But much of this pressure has only further heightened the recognition of the need for the services that many of the companies and individuals in this room provide. The industry of population health management, or service across the continuum, is developing at a rapid pace, pushed by the frustration with our sick care system and its inability to control costs while also not showing a great improvement in outcomes, the legislation, new ideas and players, technology, and even now consumerism. At the Care Continuum Alliance, we represent organizations that provide services to companies that include end-of-life case management, disease management, providers and health systems, payers, and lifestyle management. Grasp population health management is to understand that every person, no matter how young or old, how healthy or ill, has a place along that continuum. While this makes the opportunity enormous for us all, it is also so broad as to oftentimes be difficult to put one's arms around. For what healthcare company, lifestyle management company, health services organization, provider, payer, or health-related technology company doesn't fit somewhere in that continuum. And we at the Care Continuum Alliance are working diligently to provide value to this broadening array of members. Could I ask the CCA staff to please stand? I think Tracy and a few others may be in the room. I'm certain that most of you know Tracy up front, who works throughout the year as our CEO and president. She's supported by a strong team of individuals, including Jeanette May, who oversees research, Lisa Gorski, membership and development, Victoria, now Shapiro, government affairs, Cindy DeClark, corporate relations, Karen Mosley in research, Allison King in planning and operations, Isabel Estrada Portales in communications, Leon Scott, web and social communities, and Nicole Kashin, an intern. Please introduce yourselves to them during this conference and reach out if they can assist you in any manner. They have worked tirelessly to bring this conference together, and for that we should thank them. Under the leadership of Chris Kaloyan, our chairman, members of the executive committee, the board, and Tracy, the Care Continuum Alliance has successfully navigated through substantial changes in the industry in order to better position ourselves to play a substantive role in healthcare on behalf of our member companies and individuals. We have worked through a name change, but it was about more than just changing the name. It was about recognizing that we represent, and the industry we represent was broader, much broader in terms of companies, organizations, individuals, and roles. Along with this name change has been a strong effort to expand our membership, to encompass those new entrants in the care continuum, as well as continue to represent those who have been with us since our founding. The CCA has made great strides, and to date we have brought in 34 new member companies during this past year. Our function is really in 4 areas: convening, promoting, advocating, and research. The organization has been working on behalf of its members in each of these areas. We are here convening at this forum, an opportunity to meet, to learn, to develop relationships that we hope will provide you and your organizations with greater insights, new ideas, and perhaps new customers, clients, and vendors. In the area of promoting, we work actively to promote the industry. This past spring, we held our first ever Innovations Day at the Capitol, which was extremely well attended. It introduced our concepts and companies to hundreds on Capitol Hill. In the area of advocating, the Care Continuum Alliance has been advocating at the federal level on behalf of the industry and is extremely active in working with and informing federal agencies on policies within the Accountable Care Act as these agencies begin implementing and writing new rules for the myriad of laws that were passed. Our Capitol Caucus, which this year for the first time was open to all members, provided unique insights from members of the federal government, officials, agency representatives, and others. It allowed for a two-way dialogue and introduced CCA and its members to many government officials. In the area of research, our Quality and Research Committee, including staff and numerous member volunteers, have focused this year on the development of the newly released measurement guide entitled Implementation and Evaluation, a population health guide for primary care-driven models of care. This new guide continues CCA's work toward demonstrating the value of population health management in strategies and collaborative care models to help providers better understand how to adapt and, more importantly, how to evaluate the impact these strategies have on quality measures and cost containment. The Quality Research Committee has also continued an important collaboration with HERO to develop a dashboard of measures, standards, and specifications for specific domains that employers would find useful in understanding the impact of their health management programs. So what's the future of CCA look like? I'd like to propose a few areas, many of them currently being worked on. Earlier I mentioned the changes brought on by the frustration with our healthcare system. But as is typical, those in the healthcare world know it's a fragmented world out there, and all of the various oars of this system are not pulling together in the same direction. Hospitals and doctors, population health management companies, or technology all believe they have the answer and they should be the one leading the effort. As an organization, we must navigate these mixed currents and lay out an appropriate course. This course must serve the pillars of our mission, but I think we must do more than just navigate these waters. Our goal should be to continue on the excellent efforts of my predecessors to become a more pace-setting organization. The Care Continuum Alliance should be the go-to organization, the place where the experts at any point in the continuum are found, where those looking for answers come to meet with the best and brightest organizations in population health management. The CCA has experts developing and using the tools of population health management under a myriad of other names for decades. And they are now joined by those new entrants who are bringing new ideas, innovations, and technology into this space. We will work strongly to promote the ideas of our member organizations, and another key initiative will be establishing stronger relationships with the medical care organizations as they move into this new world of patient-centered medical homes, ACOs, and other integrated delivery systems, so that they may better understand the expertise and services we can bring to help them manage their populations. The CCA should be the voice heard and trusted when advocating at a federal and state level. Healthcare now moves to the states. The CCA is beginning to move in that direction too, and looking to establish those state relationships. The CCA should be the respected voice in research, not just touting the success stories, but presenting real-world examples of those things that are less successful, so that others will not repeat the mistakes that we have made, but will learn from the successes and build upon them. As we continue the development of our outcomes guidelines recommendations, we should not look to consensus that results in the lowest common denominator, but to a higher standard which measurement can be done by, and recognize that may not necessarily be appropriate places for rigorous clinical trials, but can still do sound, relevant, important research. At this time, can I ask each member of the board to please stand? Be a chunk in here. We have a very large and very good board, and it would take me a bit of time to introduce them all, but I'd like to introduce our newest nominees to the board. Sandeep Wadhwa from 3M, Mike Cotton from Alere, Mary Jane Osmick from American Specialty Health, David Nace from McKesson, Cece Connolly from PricewaterhouseCoopers, Brad Watson from and John Brooks from Joslin Diabetes Center. I'm fortunate to be working with this group and look forward to working successfully with them in 2013. And to each of you and your companies, I say thank you for allowing you to volunteer your time to this organization. I really appreciate it. We as the board are here representing our members. If you have not spoken with a board member, here's your chance. Please introduce yourself, tell us what you think, what we can do better, what's working well. And finally, if your organization is not a member of the Care Continuum Alliance, it should be all of us to convene and help put in place an integrated continuum that we know will produce a better health system and yield great dividends in the years to come. Thank you, and please enjoy the conference.
Thank you so much, Fred. Thank you, Fred. I want to echo Fred's comments about our app. Please go to the App Store and look for the CCA The Forum 12, and don't forget the Twitter hashtag CCA Forum. I now have the honor of introducing someone that frankly needs no introduction, but that's not going to stop me. Sidorov is a longtime supporter and contributor to this organization. He is a former board member, and many of you know him through his incredibly successful and witty blog, the Disease Management Care blog. Jaan has many years of leadership in this industry, first through his role at Geisinger Health Plan, and also in his role as a board and executive committee member for our legacy organization, the Disease Management Association, and now CCA. Jaan is going to help us celebrate and recognize the evolution of this organization, our accomplishments, and some of the opportunities that are ahead of us. Jaan?
I must say the music is getting a little bit out of control. Welcome, everybody. What I'd like to do in the next 20 minutes is describe a little bit on how we got here. It's no secret that healthcare has undergone some remarkable changes in the last 20 years. Yet through it all, the professionals in this room and the Care Continuum of Alliance have done a marvelous job of sticking fast to one key core principle. And that principle is that consumers, really persons, our friends, our family, our neighbors, ourselves, if given the right tools and the right kind of resources, can participate meaningfully in their own care. How did we get to this point? How did all of us end up in this room? How did the CCA Alliance become so successful? What I'd like to do in the next 20 minutes is review a little bit with you the policy, the politics, and our care for the patients, and how that really tells a marvelous story, a remarkable story of the population health management movement. Every story has a beginning. Think back to the 1990s and the great discoveries of that time, including optics of the Hubble telescope, the musical genius of gal bands, and this idea that the stock market would serve as an unending source of wealth for all of us in the near and distant future. At the same time, we also ran into a hard reality, and we made another discovery, and that was no matter how many hospitals we built, and no matter how many beds we put into them, we would never be able to meet the demand for healthcare services. From that arose a very, very interesting idea, and that idea was that if we could help patients with chronic conditions that are putting them in the hospital in the first place, we might be able to head them off in the pass and reduce healthcare costs and make people healthy at the same time. And that idea was called disease management. It was a great idea. Now, recall back in that day, in the 1990s, that the prevailing methodology of payment was still fee-for-service. So the earliest versions of disease management, which I called version 1.0, the fee-for-service business model that arose, was very, very simple and really something of a stroke for genius. It consisted of 3 key steps. The first step, hire a lot of nurses. Put them on the phone. The second step, call people before they even realize that they might have to go to the hospital. And in the fee-for-service business model, out the back end comes a lot of fees, comes a lot of money. 1, 2, 3. It worked pretty well. As a matter of fact, it worked so well that I think it's still an inspiration for a lot of the fee-for-service business that's going on today. An example is taking patients with any symptoms whatsoever, putting them through very, very complex imaging machinery, and out the back end comes a lot of dollars. It makes a lot of sense. But I digress. Getting back to disease management's rapid growth, it really worked very well. Depending on how you count the numbers, from the 1990s into the 2000s, total revenue for the industry was achieving close to $4 billion. Now, out of a $2 billion spend, $2 trillion industry, which was happening at around 2005, 2006, $2 trillion, that's not a lot of money. But for those of us that were in the trenches at the time, it truly was a bonanza. Employers turned to disease management as a way to keep employees out of the hospital, and the managed care and the HMO industry was more than happy to respond by providing models built on this to help keep patients out of the hospital. And it worked really well. The problem is that the party ended. What happened? 2 things. A report from the Congressional Budget Office in response to Senator Nichols' request for a review on whether or not disease management actually reduces healthcare costs. And the CBO, based on a very, very intense scrutiny of the existing medical literature at the time, ultimately concluded that DM does not reduce healthcare costs. It doesn't impact trend at all, based on literature, based on the published literature at the time. The second thing that happened was the Medicare Health Support Demonstration Project. The demonstration. I put the data up from these are data that later appeared in a published medical journal, and the bottom line results are that net of fees, CMS for this fee-for-service population was unable to achieve any savings. Now, this study has been widely interpreted as proof that disease management does not save money, when in fact, what it ultimately showed was that CMS in this particular fee-for-service population that was poorly randomly assigned and had very poor data support using a very, very early version of disease management did not work. In the meantime, the damage was done, however. Other very, very smart researchers began to look at the data with a whole lot of scrutiny, and this is one table from one publication, but there were several other studies that were released like this, looking at the literature that showed that the impact of disease management based on the literature was spotty at best when it came to quality, and that its impact on healthcare costs either showed no results at all, or there might have even been proof that it had no impact whatsoever. If it felt like a witch hunt for those of us in the trenches, it's because it probably was. And while we were burning witches at the stake, just about anybody with common sense, intelligence, and a calculator could look at the data and come up with and find problems with. How bad did it get? It got pretty bad. This is a report from a prestigious medical journal that showed that the worst fears of academics and policymakers everywhere was coming true. That every time you signed a patient up for disease management, somewhere a kitten in the United States died. You may know some of these authors. Don't Believe It, Maximum Bias, Dressed in Blinders, Ivory Tower. I'd like to point out that the most senior researcher in this group, Amma Peacock, was my mentor in medical school. But a funny thing happened on the way to the near-death experience for the industry. If you look back at what was happening at the time, the vast majority, 96% according to one study, of commercial insurers and employer-based insurers continued to offer disease management in one version or another to beneficiaries. The industry hung in there. These guys knew something that CMS and the academics did not know. This may be part of the explanation. This is a widely quoted slide. This is from the Gantner Group that describes the life cycle of innovations in technology as they enter the marketplace. After huge uptake and visibility, you go through the trough of disillusionment, but then with better understanding of its role in the system, you enter a slope of enlightenment and a plateau of productivity. And I propose to you that this is exactly what was happening at this time, that the commercial insurers and the HMOs and the managed care organizations began to understand just what the fit was for this approach to care in its offerings. In addition to that, the industry learned from its mistakes. It took the criticisms to heart and continued to do research. And what's more, it began to perform very, very rigorous research, and lo and behold, the studies were published in upper-tier journals, and Toto began to show that, yes, indeed, this approach to care could result in improved outcomes and also decrease healthcare costs, including randomized controlled clinical trials, including the New England Journal of Medicine. The other thing that happened, I think, is that, and we heard this about the legacy organization, the industry took a look at itself and began to think that the term disease management, quote unquote, didn't really do a good job of describing the full bucket of services that was being provided, and began to look at different names and eventually landed on the much smarter name, I think, of the Care Continuum Alliance. The other thing that happened was, instead of talking about disease, a term that makes many of your skin crawl when I mention it, began to talk more about population health management, which is a better description of what's going on. We're still struggling with that term. We'll probably come up in another term, but we'll see. This led to a huge policy reset, in my estimation. Now, no description of the 1990s and the 2000s would be complete without drawing lessons from our favorite ex-president, Mr. Clinton. Recall in version 1, Bill Clinton, he was party animal president. He has since turned into mature statesman ex-president. Version 1, version 2. I think there are some parallels for the industry here also. Back in the early days, we really thought we were the solution. Nowadays, population health management is clearly part of the solution. It's one of the key things that needs to be done to help untangle this healthcare system mess that we have. We focused exclusively on chronic illness. Well, nowadays we recognize that we have something to offer in the full continuum of care, including prevention and wellness services. We focused a lot on consumerism, helping consumers be the central focus of everything that was done in terms of the healthcare system. Well, we have a more sophisticated, more nuanced approach to helping patients be a member of the healthcare team, actually leading it under some circumstances, very patient-centric, in a collaborative fashion. Back then, the business model was one of fee-for-service, very, very transactional. Well, now, what we offer the healthcare system is great value and increasing efficiency. We used to believe that by carpet bombing patients with telephone calls that we could take the quality curve and move it in the right direction. Well, nowadays, we recognize there's been some very, very powerful research that has proven over and over again the value of risk stratification, finding the patients at greatest risk, and reaching out to them as through a process of selective enrollment to go after the patients who are most likely to benefit from the services that we provide. We talk about saving money and return on investment. Well, nowadays, when we talk about things, we're much more sophisticated. We talk about avoidable claims. We talk about altering trend. Brazenly, we asked who needs doctors? Well, we discovered that we do. We asked who needs research? We discovered that we do, and the Care Continuum Alliance has a huge commitment to this. We were held up as a silver bullet. Well, now we're recognized as a key strategy, including among, for example, accountable care organizations that repeatedly use the DM word in many of their offerings and as one of the rationales for the value that they bring to the healthcare system. We felt that we were the preeminent leader when it came to healthcare reform. Well, the Care Continuum Alliance has done a marvelous job of seeking out partnerships, collaboration, and coalitions so that it's a much more effective change for the better when it comes to working inside the Beltway in Washington, D.C. We talked a lot about patient engagement. This is the one thing that has not changed. We still continue to talk about patient engagement because this is our core mission. This is what we do. We help patients take better care of themselves, and we keep them away from the hospital, and we put them in better health than they otherwise would be. So that's the policy. It shifted. Second thing, politics. There's this thing that happened called the Affordable Protection and Affordable Care Act. It was approved in March of 2010. The graphics changed a little bit, but I think you can see that it was pretty much upheld by the Supreme Court in June of 2012. Now, unlike many of the politicians that serve us, I'm pretty confident that a lot of us opened up the law and actually take a look at it. And let me remind you that what we found was all these terms: increased primary care, pre-existing chronic conditions, preventive services, on and on down the line. These are precisely the terms that we've been talking about for the last 20 years. It's almost as if we were given everything that we felt was important in terms of serving the U.S. population and getting our arms around healthcare costs. Now, one of the problems, the Act does not specifically mention population health management, but that's because we only recently started talking about it. Congress didn't quite catch up with us, but for all intents and purposes, I propose to you that thanks to this language, population health management is a big part of the Patient Protection and Affordable Care Act. And I would also propose to you that while we're still trying to sort out the politics, both sides of the partisan divide seem to pretty much agree that these are the elements that should be a part of healthcare reform, whether the Affordable Care Act stands or not. By the way, the triple aim, quote unquote, which is also widely quoted as a part of the Affordable Care Act, is never mentioned in language. And I looked one more time and I could find no evidence that unicorns were mentioned either. The politics are continuing. As anyone watching TV just 48 hours recognizes, but we have a big problem. One of the criticisms for the Affordable Care Act is that it didn't do a very, very good job of controlling healthcare costs. And the way things are going, it looks as if 50% of us are going to eventually need healthcare. Maybe the solution to the economy and unemployment is to employ the other 50% to take care of them. The problem is that we're going to need a third 50% to help pay for it all. But that's okay. Remember, these individuals, they've been serving the healthcare industry for time immemorial and have done a great job, and God bless them for all the work that they've done. You nurses, I'm a big fan of you, and so is everybody else in this room. But in addition to nurses and other non-physician healthcare professionals, we've come up with this model. And this is where the rubber hits the road in many instances. Backed up by the kind of technology, they're mobile, they're smart. In many respects, they're applied behavioral medicine specialists going out there and doing great things. And when the Affordable Care Act begins to actually try to make things happen, I propose to you that our industry, armed with these, make it happen. So we've gone from disease management to population health management, from version 1 to version 2. Makes no difference where these patients are. They might be on the verge of leaving the hospital, or they may already be home. We'll be there for them. They may be at the gym. We can help them do a better job also. We'll do it in classes. We'll do it one-on-one. We'll do it remotely if that's what it takes. Patients are becoming, people are becoming, consumers are becoming increasingly connected. We can use remote technology. And then, of course, it's handheld devices. And during the remainder of the conference, we're going to learn how to do this smarter, better, faster, and cheaper, because that's what the industry is all about. This is the reason why the next 20 years are going to be as exciting and as interesting as the last 20 years. Enjoy the conference, everybody, and I think you'll enjoy this very much. Oh, I'm being given the okay for questions, in case anyone disagrees with me or wants to correct me. I think everybody wants to hear the next speaker. Sure, thank you.
Ladies and gentlemen, please welcome Executive Vice President of Healthways, a recognized pioneer in our industry and a charter board member and former president of CCA's legacy organization, the Disease Management Association of America. Please welcome Bob Stone.
Good morning. I noticed that I'm the only one so far who's used a current picture. I'm keeping track, y'all. Healthways is pleased to be the sponsor of this morning's session, and it reminds me that the last time I stood on this stage was to deliver a State of the Association message as its outgoing president. That address lasted 45 minutes. And I'm sure everyone will be relieved to know that my comments this morning will be considerably shorter, but hopefully at least partially as useful. Before I fulfill the real function of introducing our very special next speaker for this session, while we remember an individual whose contributions to both the association and to our industry were critical in their formative years. I'm speaking of Warren Todd, who, as many of you know, passed away suddenly earlier this year. Warren was truly a pioneer in the industry, having established one of the first asthma programs for the National Jewish Medical and Research Center in the early 1990s. He published the first book on disease management in 1996. And in 1999, he joined with a small group of industry leaders to lay the groundwork for this association. Warren was one of our charter board members and was elected the association's second president, as they were called then, in 2000. CCA recognized his contributions, then the DMAA recognized his contributions to the industry by awarding him the prestigious Recognizing Excellent Award as the most important individual in disease management in 2001. In that same year, Warren assumed the responsibility of becoming the association's first full-time executive director, a position he held in 2005. During his 6 years at MAA, Warren provides both the leadership and operational support behind the exponential growth of the association, its financial success, its double-digit growth in annual conference attendance, and passage of important legislation, including DMAA-friendly HIPAA legislation and the national seat of DM around the world. These international efforts have helped lead to the establishment of 3 DM associations overseas in Germany, Australia, and Japan, plus expressed interest or actual provision of DM services on 5 continents. Warren also lectured and or provided consulting support in 12 different countries. I don't think it's hyperbole to suggest that Warren had significant impact on our becoming both the industry and the association that we are today. And I would ask all of you to join me in a moment of silence and reflection in memory of his commitment and his unique and important contributions. Thank you. It was 48 years ago, and I'm not going to ask who in the audience was alive then because the number's getting smaller every time I do one of these. 48 years ago that Bob Dylan advised us that the times were a-changing. Now, on the other hand, 115 years earlier, Jean-Baptiste Alphonse Carr wrote, "Plus ça change, plus c'est la même chose." For those of you who compulsory French, the more things change, the more they stay the same. And of course, we're all familiar with the 1905 observation by Santana, the Spanish philosopher, not the band, that those who cannot remember the past are condemned to repeat it. Now, as disparate as these 3 observations seem, they are, I believe, reconcilable. And in fact, I'd suggest that unless we, this association and its members, are successful at reconciling them, the promise of this organization, this industry, and the promise of healthcare reform itself will be realized. So here's how I think the reconciliation works. First, the times are a-changing. Every speaker at this conference so far, and I dare say every speaker who follows, will emphasize that point to one degree or another. And I suspect that everyone in this room would agree that the changes we are facing for the organization, delivery, and payment of health care services in this country are likely to be the most significant perhaps since the introduction and implementation of Medicare in 1965. Second, many of the responses being put forth to address the changes we see coming have been tried before, albeit under different names, and at least for some, as Jaan pointed out, clearly failed. Unless we identify and address the root causes of those historical misadventures, we are, in fact, I suggest, likely to experience a similar result. Third, even in the midst of unprecedented change, there are elements of what we do that must and do remain unchanged. In our industry, the most obvious is that we must develop ever more efficient and effective science-based and scalable solutions that are delivered to entire populations, one individual at a time. For at the end of the day, all of the other things being equal, our success or failure will be determined by our ability to sustainably engage individuals in their own health and well-being. Our speaker this morning is uniquely qualified to help us better understand the dynamics of forging and maintaining a trust relationship that is fundamental to sustained engagement. Dr. Joseph Coughlin is the visionary founder and director of the MIT H-Lab, which was founded to invent new ideas and to creatively translate technologies into practical solutions that would improve health and enable people to be productive throughout their lifespan. As its director, Dr. Coughlin leads a multidisciplinary team of researchers who seek to understand how demographic change, social trends, and technology converge to drive future innovations in business and government with a particular focus on understanding individual behavior and choices. Joe's research and analysis of consumer trust and confidence is fresh and informative. It also comes at a perfect time, for it will be critical in helping us determine who is our real client and how can we continue to be powerful advocates in shaping the future of total population health and well-being improvement. In addition to being director of the Age Lab, Dr. Coughlin is a prolific author, speaker, frequent media star. He is cited routinely in publications like the Wall Street Journal and the New York Times. For those of you who missed his centerfold layout in the Financial Times last year, he will be similarly showcased in next month's issue of Money, and you don't want to miss that. Joe asked if it was okay to be provocative and challenging this morning, and I assured him it was. For only by challenging and testing our historical beliefs and biases will we be able to bring out our best thinking. Joe may look like a traditional academic in his professorial bow tie, but do not let looks deceive you. What you're about to hear is a provocative new approach that will challenge our traditional way of doing business. And so without further ado, please join me in welcoming Dr. Joseph Coughlin. Joe?
Well, you set the bar awfully high, I think, so hopefully I'll be able to deliver. Good morning. Come on, more Starbucks we need, I think, as an IV. Good morning. I was hoping that you'd do a little bit Jimmy Buffett when I came up, but I guess we're toning down the music. Folks, I'm really happy to be here. I want to thank Bob and Vicki Shepard and her colleagues at Healthways for inviting me, Tracy and her team for having me this morning, and all of you for sharing 20, 30 minutes of time to celebrate, frankly, for a moment, how far this organization, this emerging profession, and frankly, business of continuing care, disease management, language will continue to change, mission will continue to context. So take a moment and celebrate. Okay, that's enough. Because frankly, every moment that you celebrate and think how far we've come, we have to celebrate that to give us the juice to go further. Because what I'm hoping to provide to you today is a little bit of insight of how the context is changing, how the client, the customer, the patient, it's even the language there continues to change depending on who uses it, what their demands are. But also, I really want you to help me think out loud this morning. I don't want to present to you what I think is an answer. I don't have that. What I want to present to you today is as Bob put it, fresh thinking that's still in process. And so I'm actually asking for class participation today, that'll be 10% of your grade, to think about not where you've been, that was done brilliantly this morning with Jaan, but now where are you going? And by the way, always remember, a new technology, a new solution solves one problem and causes at least two more. And so what you really want to think about is where are we going to be and what do we have to navigate in the near future? I'm very fond of the graphic that I use as my cover slide typically, because usually it means that I'm not the only one in the room with a haircut, but I see that Bob and a few others go to the same barber shop I do, so I don't have to be too concerned about that. Yes, I typically talk about aging, and this will be the only part of my deck here that talks about old age. But I want you to start thinking about a new number. I want you to start thinking about the idea of what it might mean for a population to begin living to 100 years old. How does that change your business? It's changing everyone else's. Do you really believe that the education you got from 0 to 21 or 0 to 25, whatever it might be, is going to last you for 75 more years? Everyone here who has an iPad, please raise your hand. That's the new normal. It's only been here, for 3 or 4 years? The technology continues to move. Our education continues to move. In over 100 years, how do you manage and govern and motivate around perhaps that long? Because many of you may have seen this article in The Lancet a couple years ago that did suggest that half of the children born in the so-called rich world will live to 100. I suggest to you that changes dramatically how we actually approach behavioral change, what motivates folks, and also, frankly, what they're going to be facing. So here's the challenge. Can we bend the curve? Old age, painfully for me, and I think many in this room, I would argue starts at about age 40. Because in my case, I grew up in Philadelphia. That means I believe that scrapple, cheesesteak, and frankly, tasty cakes are basic food groups. And cheese comes out of a spray can, not out of a cow. So as a result, about 40 or 43, various disease conditions start to crop up. And if you chose your parents badly, that makes it even worse. But now imagine what this means in terms of trying to adjust this curve for a population that may live closer and closer to 100 years. So let's talk about that new customer, client, consumer, whatever language begins to evolve. she, and I'll explain a little bit later what we mean here, is going to be older. Now, what does that mean in terms of being older? Is it just the comorbidities that are associated with that? It means in many cases that she is going to demand and need more time, more interaction. And I want you to think carefully as we think about all the technologies that are out there that I'll talk about a little bit here in a moment. What is that type of interaction? What is she going to decide is quality interaction to talk about those different comorbidities, caregiving responsibilities, and the like? Relatively healthier, and yes, I will caveat that. Many of you know these data far better than I. She is also better informed. I didn't say she was right, but I did say that she has access to information, and as a generation, most of us have gone to school far too long, leading us to believe that we're far smarter than perhaps we are. But as a result, those perceptions are brought to the forefront as to how we actually perceive what is good care, what is acceptable care, and frankly, in many cases, what is affordable. A smart consumer. The new vernacular out there is not how much I can pay for health care, but what can you do to make me smart? Part of engagement is not just giving me information, but giving me knowledge. And I want you to take a look at not what's going on in healthcare, but the true belief I have at the lab and my colleagues have as well is that real innovation to understand where your client and patients are going is going to be based not about their comparison of one insurer versus another, one management company versus another, or one technology versus another. But every time they go to a retail store, every time they go to the bank, every time they go someplace else that is trying to engage them at the same level, in many cases, in many different ways, more often than you, they're going to measure that is how they like to be talked to, how they like to be touched, how they like to be reminded to do all the things that, by the way, we're here talking about healthcare. We think that we're the most important. Right down the street, there's somebody talking about finance because, hey, you can have your health, but if you don't have your 401k, which, by the way, is now a 201k, good luck with that. So many people are trying to engage. How smart can we make them? The other day job, caregiving. Many people out there are managing the health of others. What does that mean for the business? Busy women. Before, I used to think about just the role of women in healthcare. But one of the things I really want us to think about today is that as I walked around the floor last night at the reception, brilliant reception, great food, and one of the great things was I haven't been to the speaking before you for a number of years to see what we said was going to be the future actually happen. But now the question you have to ask is, if you're trying to influence busy women as patients, as caregivers and the like, do you really think giving them more data is the way to go to engage them, to make changes in their own lives, let alone others? And then finally, the world has gotten far more complex, both for ourselves, for others, and for those that we care about. So that's just the lay of the land perspective. In a minute, I'll come back to our joint, if you will, the royal we perspective in a moment. Ill but not sick. That's what we're hoping for. As we age, as we go through life, we know we're going to have a couple chronic conditions, whether it's hypertension, diabetes, and the like. The challenge for the industry and the demand from the consumer is going to be, I may be ill, but can you keep me from being so sick that I can't work longer, that I can't volunteer, that I can't walk a child or a grandchild or just go out for a cup of coffee when I want, how I want. You know, one of the research projects we have in the Age Lab is what are you going to be doing after 65? We don't use the R word, because the retirement word, because I think that's loaded and has all kinds of symbols and metaphors associated with it. So we've so far collected 13,700 responses around the country asking people, name 2 things you'll be doing after age 65. Does anyone want to volunteer what the lead thing is? Working. I heard a dominant and I heard a bunch of other things. Work. The new, shall we say, proposal I would suggest for being healthy is not the old-fashioned, if you got your health, you have everything. But for most of us, we're planning to work for economic reasons, social connectivity, and a sense of purpose. If you're going to work, you better have your health to be able to be in the workplace, to be productive, to be well, to be able to to raise that 401k balance. Educated and research savvy. You know, the next generation of older adults and all of us here have more college education and frankly even high school education than any previous generation. That's the good news. On the other hand, I can show you any number of people with lots of degrees that can't tie their shoes, but there's the belief that they can be good researchers and they can figure things out. The fastest growing segment on the internet right now are those 50 plus. So what we're looking at now is an evolving customer who's got enough education to believe that, if I had time to do the neurosurgery, I'd do it myself, but I think I'll. And most people that are going on the web doing the research, by the way, guys, it's mostly women, going on the web are looking for information on healthcare. And we'll talk in a moment what that kind of information they're looking for, followed by financial decisions and automobile decisions. But essentially what we're now looking at is a consumer that believes the data are out there. The information is out there. I can get it if I have the time, and I can distill it. This has profound implications for what we all call expertise. Letters after your name no longer is going to be a reason for me to trust you, listen to you, or frankly do what you tell me to do. How many of you think you're smart? Come on, you can raise your hands. Oh, come on. We know that. We know, especially for those that are out there born between 1946 and 64, raise your hands. Okay, these are the baby boomers, the whiniest, largest generation. We've got a real attitude. By the way, the ones who did not raise their hands, the younger people would wish you'd just go away, and the older folks would just wish you'd shut up. But we do think we're smart. And I want you to start thinking in terms of what is this consumer experiencing throughout their lives and are going to be looking for in terms of appropriate engagement strategies. How many of you go to Costco? Why do you go to Costco? For the fun. Think about how Costco makes money. Yeah, they sell the infamous tuna fish can that's this big that you really don't need, but really they make their money on what they call treasure hunting. It's the stroll down the aisle as you're looking for a piece of salmon this big for a party of two, and you say, hey, this is a name brand, whatever it is, and it's a reasonable price. You quickly pick it up, you run out to the parking lot, and you're parking right next to a Ford 150, and on the other side of you is a Porsche Carrera, because regardless of income, the new consumer value, now that we have less money, is how smart I was to make a good buy. So giving me the power, the information to make that choice. At one end of the economic spectrum. But how about Walmart? Has everyone been to Walmart lately? What do they call the television network inside of Walmart? The smart TV network. How to make the right choice, the right time within a budget. Now, I bet a few of you, especially since we're talking about health, like to go to Whole Foods, AKA whole paycheck. Now, you can eat organically, you can eat well, but Whole Foods has finally got it. Have you ever noticed, by the way, when you go into the produce aisle, that rather than just shopping for a green apple, there's a full family history behind the apple, where it was, who picked it up, and like, well, they have now developed in-store navigators to one, not with an app, but one-on-one, go through the store aisle, saying what is it that you're looking for, what are you looking for your family, and what's your budget. A handheld experience to make the right choice at the right time. So whether you're a smart patient, a smart shopper, the new value that the consumer is expecting and experiencing everywhere is how well you can make a good decision. But I want you to notice something. The trend line amongst the retailers is hands-on and digital. It's not just digital, it's a person in the store working with you. So health services, we tend to think about, but one of the things we need to think about as well, particularly because of caregiving, is that the user is very different from the buyer. 1 in 4 families, according to the Gallup Healthways Well-Being Index, is providing care to an older adult upwards of 21 hours a week. As a result now, you've got an entire generation of people out there taking care of folks with multiple comorbidities and reaching into their pocket, according to AARP data, of anywhere from $200 a month and up to help with food shopping, medication, housing, and the like. So as we start thinking about how we design these new technologies, yes, we have to make them designer-friendly, but the value proposition has also got to be for the #1 technology used in caregiving. Does anyone know what that is? Come on, I saw a few engineers out there earlier. What's that #1 technology? And by the way, I love trick questions. No, it's not a cell phone. It is a 47 to 57-year-old woman holding a cell phone that is doing it. So as we start thinking about what the solutions are, don't just focus on the patient alone. Back up and remember when before we had social networks, we had friends, and ask yourself who the friends are and who the family is that's going to be governing, if you will, that intervention to make sure that mom or dad takes their meds, gets to the doctor, and all the other health issues. And by the way, if you don't believe this is costing money and time, MetLife and AARP estimate this is costing anywhere from $30 to $50 billion in lost productivity for that adult child leaving work early, coming to work late, not taking a promotion or not relocating because they need to provide care. So as we start thinking about what that next generation of intervention and services, make sure you design for the user, but design a solution for the buyer. So speaking of the buyer, she's busy. Now, if you talk to Procter & Gamble, if you talk to Johnson & Johnson, and the folks in the health insurance industry, even if she's not employed, she is spending 80 cents on the dollar of all healthcare decisions. Guys, you might as well go have a second Danish, because frankly, in terms of healthcare, we're not really making a big play here. They have more degrees now, as women have more degrees in all fields of study except for engineering, in bachelor's and master's degrees. Frankly, they live longer than men, but they're also going to be probably sicker in the end in terms of men. But they are the family CEO. So the following, I want you to check your brochures, your websites, and the following. If you are offering a woman who is doing the following, taking care of her parents, taking care of kids, has a husband who can't make a peanut butter and jelly sandwich, and you're offering a brochure that says, I'm going to provide you with more data, with a product, I'm going to provide you with a new service. Ladies and gentlemen, you can see a lot by looking, as the words Yogi Berra used to say. She is very busy. She wants a solution around care. She wants for her family, for her extended family and elders. And by the way, if her husband does not have an older adult sister, she's taking care of his parents as well. So giving her more to work on her cell phone or on her desktop at 2 o'clock in the morning or in her cubicle at the office is not necessarily a blessing. Can you take the data, can you take the information the next step further and tie it together so that she gets the job done? Are you a solution provider or are you a data provider? The other thing a customer out there is feeling is complexity. Have you looked at the media lately? Now, all of us in this room generally are healthcare professionals of one sort or not. Researchers, policy analysts, technicians, clinicians, whatever it might be. We are used to the change in science. We're used to writing one study, and let's be honest, as an academic, I can tell you the truth. Our business is we write one study, standing on the shoulders of somebody else, and then the next person's job is to trash what I did, to say what I missed, to write something else. We're used to that continuing flux, that continuing new norm. So I want to ask you something. If you're a patient out there, or you're caring for patients, as a family member that is, can we wait for the industry to get it right? You know, you could have years ago been feeling good and getting worse at the same time when they changed the hypertension numbers. Cholesterol, they changed what was high, what was low. Remember the food pyramid? We worked really hard in middle school to learn the food pyramid. Then they changed it a little bit into this little spiral thing, and now I've got a food plate. And by the way, 2 weeks ago, chocolate is now bad for you. And by the way, red wine apparently is not as good as they thought. But wait a minute, vitamins are good. No, last night they said vitamins might be good for some men. One of the issues we've got is as we're providing information to the consumer, there's an awful lot of conflict out there, both in the media and what they're seeing and not seeing. So psychology is that when people are confronted with lots of conflict and information that conflicts, 90% just shut off and 10% just get outright angry. So be careful what we provide, and can, as one of your service offerings, provide clarity and simplicity as to how to distill the information that's out there. So let's talk about the media a little bit. Because, you know, the media, as they say from the communication studies, cannot tell you what to think, but they can tell you what to think about. And so we cannot take our client or our patient in isolation and, like an economist, believe that they are quintessentially rational. If I only call you, you'll take the med. If I only give you the information about your diet, you'll see the light. Well, I don't know. In the last 10 to 15 years, we've done a very good job at socializing the consumer out there that healthcare is a mess. It's in a crisis. In fact, not only is it a mess or a health crisis in terms of cost or quality, but frankly, now we've got all kinds of new events out there that are making problems, whether it's the 2004 event, I believe, around Vioxx, to more locally from where I'm from in Boston, the meningitis scare that's going across the nation. Consumers are paying attention to this and putting it in their frame of reference. Who do you believe? Who should you trust? And what does that mean for me? And by the way, let's talk about trust. Remember all those guys that had their hands up, the baby boomers? I don't know if we can blame this on a generation or we can blame this on events or what it might be. But as soon as the first wave of baby boomers became adults, the following answer to the question, most people can be trusted, went from a near 60% of the population saying, yeah, that's true, to a steady decline over time. Now, I'm going to pick on a few of you in the room. You know the only people that make lawyers feel good are health insurers. Because in terms of whether they can be trusted, lawyers are at 11% of the population says, yeah, they're not bad guys, but health insurers, about 9%. The fact is that as a system, Americans do not trust large systems, large institutions. Within that, though, they do trust their doctor, their congressman, and maybe in some cases their insurer. It has to be very personalized for them to trust them. So what does this mean, though, for healthcare? If I'm having a lot of information thrown at me, there's a lot of complexity, but I have very little trust, who do I trust? So think about the math behind this. 64% of people over age 45 believe that they have an IQ. Think about the math on that one. 74% have a great deal of confidence in themselves. What they're all looking for, however, and this is the new expectation for healthcare and every other area, is that someone to help them cut through the clutter, not necessarily to give them more. More sometimes is not better. Sometimes more is just more. So who do they trust are other people like them. Now, I'm not going to get on the social media bandwagon because essentially the social media bandwagon to me is another way of extending, reaching across the white picket fence or wherever we used to talk to folks to find other people like me. So all kinds of gadgets. I don't buy a single gadget until I go on cnet.com to find somebody who's in my budget range who's equally incompetent to find out what it is that I should buy. But the fact of the matter is that as we think about who we trust, we now are having less trust and expertise, we have less trust and authority, so now we're trying to find other patients or other caregivers that are like ourselves that can share that experience. And by the way, we really like advice in our living room. So whether it's Facebook, ePinions, Cafe Mom for young mothers in particular, or Angie's List, even the 65 plus. Remember a number of years ago on this very stage, many people were saying, well, we have to be careful with this internet intervention because the older population doesn't like it. No, 1/3 of the population now over age 65, according to the Pew Center, is actually using social media. It's no longer an issue of digital divide. It's more a question of what are you doing once you're on there. And this is the big issue that I think that we have to confront, and particularly those of us in the ivory tower aren't quite used to this. It is the leveling of expertise. Suddenly now that so many people have an education or a degree or are able to find information online, look what's happened on Angie's List. Remember Angie's List was created to give opinions on painters, plumbers, fix the house. Do you see what's circled there? Now we can do dermatologists, we can do elder care, we can do plastic surgeons, we can do plastic care, because after all I'm doing is contracting out for yet another service. And so if you start looking at what the customer is looking at, there is respect maybe for their doc, but I want to come back to a moment to see whether or not are we distancing ourselves from our doctors in such a way where they're frankly just another guy or gal providing me a few minutes, emphasis on few. So here's what I think the future of advice and the future of information seeking looks like in healthcare and many other areas. Do we have a do-it-yourself society? No, not quite. People are going online, I would suggest to you, to frame their problem, to think about what it is that they want to do. And then they're going to the people they trust. Friends, family, this could be online. And by the way, if you're a woman, I think all of you would agree the following, whether you think about it or not, is that women in particular all have their own board of advisors. They've got a friend for fashion, a friend for finance, a friend for deadbeat fiancés, whatever it might be. They've got the go-to girl to be able to ask that question. And then they go to the professional advisor, which may be the pharmacist, maybe the nurse, maybe the doctor, but in many cases, they don't pull the trigger to make the decision at that point. They go back to re-research it, re-vet it with a friend, and then finally go. What is the implication? The implication is the following. One, the questions coming to that clinician or whoever's providing the advice is far more complex and far more comprehensive than we've ever seen before. As a result, they're going to have more time, a greater repertoire of discussion around the entire context of what people are asking about. So let me give you a little bit of vision of where we are. By the way, a fine line between vision and hallucination, of where we are and where we're going in terms of technology. But then that's where I want you to hear me think out loud, and hopefully we'll have a few moments for you to either contest what I have to say or to reinforce my worry. So we've got all kinds of great technologies. A number of the folks downstairs had really stuff downstairs that can touch us in many ways, from on our cell phones, in our purses, to our homes and the like. And where that technology is going is quite clearly the following. One, we're going to start losing the instrumentation, and we're going to start putting it underneath our skin. So we've got 2 sensors here. They're already going into trials for being subdermal sensors for everything from diabetes to blood pressure and the like. Your underwear, quite literally, will have sensors that will be talking probably to your refrigerator, and will be talking to your car, which will be talking to the grocery store. And yes, it's going to be personalized, because we're going to be swabbing you to get your genetic makeup to be able to do the personalized medicine. This spoon, for instance, is the bane of my existence. It was developed by a colleague at MIT. It allows you mixing up one of my vices, and you have to have at least a few, is to make chocolate brownies. And it will be able to detect not just the viscosity of the mix, but the sugar, the cholesterol, and fat, and then upload that to the dietitian who's been watching me carefully, or telling my wife. And either way, I'm in real trouble. But the real trend line is the following. To steal from Motorola, intelligence everywhere. So don't get too hooked on the device. As you start making a business model, it's not about the toy. Ask yourself about the iPad, because the toys change too fast for you to anchor yourself to any one thing. 2, it's going to be wearable or inside of you very quickly. The big thing, innovative service models. If you're not driving a solution, then you're only selling a widget, which becomes commodity over time. So as a result, can you create partners around your widget, an ecosystem of innovation to make it valuable? Ask yourself the following. I know it's become a trite example. What would Apple do? Apple sells great design hardware, but all the other systems and services around it give it the barrier, give it the presence in the marketplace, and makes it an innovator. One of the places I think we should watch even more, I saw some colleagues here earlier from Walgreens, but retail. Health is moving retail in a very major way. And I don't mean just the strep check and the flu shot, but very quickly, whether it's Boots in the UK or other places, you're going to see disease management in the old vernacular, and frankly, some of the caregiving services being moved into the store, with store aisles being designed around what that patient needs. Because she is demanding total solutions. And when she has a problem, she goes retail. And there's one example in terms of what was being done out there. This is a device we developed in my own lab for Procter & Gamble. Parts of this are in the Metro stores in Germany today. It takes your personalized diet, allows you to go through the store aisle, and to use today for barcode, RFID in the very near future, allows you to swipe the Ghirardelli brownie mix and say, gee, Joe, you're pre-hypertensive, pre-diabetic, put the fatty mix back and move to something else. But the something else can't be an apple, because human behavior doesn't go from chocolate brownie to an apple. It's whether you can nudge them gently in the other way. So the idea here is, can you provide me with the right information at the right time to make the right choice? Because frankly, I don't care how many phone calls you give me and how many people on social media give me a hard time for what I'm eating. Once it's in the cart and in the cabinet, it's going to be in my stomach by Friday night. Integrated home services, not devices. Now I know I'm probably confusing you by showing you widgets, but I want you to think about what are the solutions that the customers out there are going to be looking for. So I've got Panasonic and Tokyo Electric Power out there as an example. That little kitty cat, tiger, whatever you want to call it, manages and monitors motion in the home to make sure mom is moving and doing well, allows you to upload glucose, blood pressure, like countless devices out there. But here's the difference. You plug it into the wall, uses the internet bandwidth that you can get from the power outlet through Tokyo Electric Power to get to University Hospital in Tokyo. The result is that what they've done is they've created a widget that costs how much? Near free. Near free, because they realize the device is only a gateway to providing a service. The service solution is paid for through the utility company, and the technology changes in and out. Get ready to see technology be like your cable set-top box or your cell phone. It keeps moving. What you got to keep your eye on are what is the service that you can provide to the customer and to the patient for better outcomes. Don't ignore the gaming industry. They're going to blow us all away. What's next is not better connectivity. What's next is more fun, and it's going to come through PlayStation. It's going to come through Wii. These are the new channels, if you will. And frankly, one of my favorite examples that I always use, because it's still out there, it's gotten cheaper, and it's coming to the United States, are smart toilets. Now, we're close enough, or shall we say in between breakfast and lunch, where I can description, but I'll keep it in computer science vernacular. Smart toilets. Anyone been to Japan or Korea or Israel where they have a lot of these? Okay, have you been attacked by a smart toilet? No. Smart toilets don't do the washing of the nether regions that we will leave off the map, but they download, shall we say, from the user body weight, body temperature, did you take your pills last night, what did you eat, and then upload those data via the internet to a call center or whatever management function is looking at those data. However, this particular toilet is on a trial run now with one of the larger retail chains in Europe to do all the things I described. And by the way, these toilets are made by Panasonic, some very real companies behind them, and then, shall we say, facilitates home delivery of the food product that your toilet sees is missing from your diet. Friends online and wellness online, reinforcing behavior. I don't know where we lost common sense, but from the 1920s we knew this, and our mothers knew this as well. Remember, our parents always said, be careful who you hang out with, people will judge you, birds of a feather, all this other nonsense. Well, it wasn't nonsense. Somehow the economists and the engineers, and frankly even those of us in the healthcare professions, got so rational we believed, okay, I'm going to tell you what's good for you, this is logical information, and you're going to do it. And then we're sitting here going, oh my God, they're not complying. Why? Do you ever go to a shopping mall? You go into the shopping mall, you see something that's fun, and you have another friend reinforce that that's fun and that's cool. Then you do it. We're just teenagers with more money. Essentially, what we need to think about is that the future of online is not just about the sharing and the data mining and the like. No, the future of online is taking people as you find them, which is they want friends, they want fun, and they want fashion. We now have to make being healthy not rational, not cost effective, not a population outcome. We've got to make it the new cool. That's what's going to motivate people. And using online to make it the new cool from 0 to 100, I think will get us there. And if you don't believe me, go to a shopping mall and look at all the idiots buying a $100 pair of jeans just because some teenage friend said, hey, that's a good idea. So let me wrap this up with some questions, and I have to tell you, concerns. Now, the Hindus take credit, the Buddhists take credit, but we all know the story of the elephant and the 8 blind men, correct? Basically, the 8 blind men touch the elephant, and one says it's a palm leaf, one says it's a tree trunk. But here's the question I have for you. We are all creating, and we use the word all the time, our phrase, health system, a continuum. You know what the trouble is? We don't just do that in this room. We're talking to the patients that way, too. We're talking to the customers that way, the clients that way. They don't know what a continuum is. They don't know what a system is. They just know if I'm sick or I need to be well, I want to do something. So as we're touching this elephant, we've done a great job of bringing technology together with an interest in behavior, and we've made measurable benefits in population health outcomes. We should take pride in that, or you should take pride in that. I get paid to watch. But the fact of the matter is, the elephant, we're not sure what we've created. So if you listen to the words, and I teach a course on health systems we use in the profession, and if you look at the accountability care bill, and you look at everything else out there in our world, we talk in terms of quality. We talk about affordability, interoperability, acceptability. In systems engineering, we call this the ilities. These are the characteristics of a good system. That's the way we talk, that's the way we model, that's the way we make products, and that's how we market it. Because now let's take this flip. By the way, these are discussion words used by professionals out there from data online. Now let's go online and ask patients, how do they talk? They don't know. They use words like health, recommend, their personal time, the doctor's relationship with me. They actually put all the other words, if they show up at all, very much on the back burner. But more importantly, the big thing that my students found, this is new data, found by looking across social media sites for the past 2 years, this is the biggest theme out there. They want a straight, simple talker. That's the number one characteristic they want from a clinician, whether they're doctor, nurse, dietitian, whatever it might be. What are the systems, the services, and the technologies that we can do from the health consumer's perspective to cut through the clutter, trusted advice that's simple with great clarity? So let me suggest to you what we've done with that elephant called health systems. I know we're talking about medical home model. I know we're talking about physician patient-centered model. But is it really evolving that way in reality? Have we set into motion something that in 10 years we're going to turn around and go, how did that happen? So I'm going to show my own age. I use Dr. Welby because I think in the American mind, the classic doctor that we all want is Dr. Welby. He knows the family, he knows us, he spends lots of time, he visits the house. How many of you have that doctor? And by the way, I love doctors. You can't have that doctor unless you pay a crazy amount and a doctor who said, I'm going to have a small practice. At one technology or the reality that we did have that doctor. Matter of a few years, remember we used to have medical arts buildings. Now medical has gone to medical science and the like. But now what we're looking at is doctors that are squeezed where the average time spent is anywhere from 7 to 19 minutes. Is that the kind of time that Dr. Welby played with? How can you have a, quote, relationship in 7 to 11 minutes? So what we've done now is we're evolving to the next step, which is the practice or the team approach. If you look at the slide of having multiple touch points, we think that's better. I want to ask you, do you have lots and lots of good friends that you trust all the time? Or do you have one or two? How does that interpersonal relationship change? And then we've gone from this big practice model of don't worry, you're in my practice, all of us will take good care of you, to the retail clinic model. So now we've gone a step further saying, well, all I need is X. It's a very mechanical thing to provide. And then the next step, of course, is the following. It's tele anything, telemedicine, it's this, it's that. And so as a result, we've gone from the personal and the relationship and the emotional to the profoundly rational. So what is this going to do now in terms of what we're looking for in that relationship? So if we look at the next slide, the question we have is what has this done to what I would consider distributed trust? How far can you push that patient-doctor relationship to the next step? And generally it stops at the nurse. Because after the nurse who spends more time with you, who else can you trust? So as we create these communities of service providers, do you really believe that that nutritionist is going to be as lovey-dovey to that patient relationship as the patient is with the doctor that they hope they can spend more time? So how far does it go? Trust is inherently personal. And how many of those people can we trust and move it over? And will technology enhance the relationship, or will it do what it has done for the banks? We've gone from a bank teller we knew once a week to an ATM to something mobile, so now it's just a transaction and not a relationship. So if you ask customers out there who's responsible for their health across generations, whether they're boomers, Xers, or Echo, now I know they're not doing much about it, but the vast majority of them believe today, according to the Futures Group, they are responsible for their health. Look where they put the physician. Now, they love their physician. I don't want to take back from that at all. And I've seen the doctor's job. I wouldn't take it for a life. Or the nurse's job. I wouldn't take that either. But the fact of the matter is that the distance that we are now putting between us and that relationship due to time, money, technology, and a variety of things, I think is having an impact. And by the way, information. Can we have too much of a good thing? Think about how much information we are driving to people, not just for health, but for finance, for retirement, all the other clutter things that are in their lives. We are adding far too much. And how much of that can they process? And when do you cross the line between data, becoming information, becoming knowledge, becoming action? Right now, whether it's stuff we can wear on our watch or on our belts, I see lots and lots of data being visualized in cute ways, but nothing that can be translated into profound action yet. And by the way, the consumer thinks so too. So whether it's the boomers, Xers, Generation Y, all the folks that love technology, look at this. There's so much being written these days about health that it's difficult to know what you should and believe. One more brochure, one more website, and we're going to have a revolution. So let me conclude on the following, and hopefully we may have a moment for questions or taking umbrage with what I had to say. One is, yes, customer service, important. We're focused on that today, but really customer education. And I'm going to propose to you that while the doctor has tried to do this, he or she does not have the time. There's a shortage of nurses as well. She doesn't have the time. What does that next generation educator, coach, agenda setter look like? MD-patient center relationship? Yeah, it's important, but you have to focus on the social network. Again, the like. We may be finance focused in terms of, shall we say, how much it costs, but frankly, it's got to be solutions focused. What is it that I need in terms of my actual care to get it done within the time, the tyranny of trade-offs that we call life? Population-based health, I know that's the current word, and that's how we all get published in my world, but at the end of the day, the customer believes that they are a segment of one. Can you give me personalized care that gives you the population outcomes you're looking for? Define touch points, whether it's on my belt, whether it's a phone call, whatever it is. But frankly, if you look at successful retailers, companies that know how to engage consumers, it's 24/7. It's on the radio, it's on the TV, it's in the it's everywhere. Ask yourself now how Apple would do it, but since they're one of the problems one could argue out there, how would McDonald's do it? They do it very well. Facts and fear. Do this, or you're going to be eating cat food, or you're going to be dying early, or if you don't eat this, it's not healthy for you. Those are the two bookends of how we try to motivate people, when in fact we know it's fun, friends, and fashion that get people to open their wallet and to change their behaviors. Disease and illness, it does matter, it's painful, it's costly, but frankly what people are buying is proactive vitality. They see themselves more likely to be dead, therefore they buy life insurance, than they see themselves buying services, abilities that they can't imagine that they would ever have. So as a result, start thinking in terms of health of what it allows you to do, not necessarily how good it is in terms of cost, how good it is in terms of quality of life. So on that note, I thank you very much. Tracy, I don't know if we have time for questions or not. Thank you. So please, someone tell me that I'm being a worrywart, and as a typical academic, I don't understand what's really going on in the real world. Who gets to spend more than 17 minutes with their doctor? If you're over 50, you get 22 minutes. Come on, we all love the technology. I mean, I've got more widgets in my bag and on my wrist and everything else, but I'm getting lots and lots of data feed. I've now got a whole new job to make sense of the information that people are sending me that I've elected to sign up for. How can we take this profession and improve the relationship and bring in another E word, not economics, but emotion? Because emotion is what gets behavioral change. Emotion is a relationship. Emotion ends up with better outcomes. Question in the back. Fear, guilt, and shame. You were raised Roman Catholic as well? No, okay. So, no, absolutely. I think that, if you look at studies, again, my wife calls what I do the science of the obvious. If you look at behavioral sciences of why men fight in war, they don't fight because they believe the other side is evil. They may believe that, but that's not the reason they fight and die. They don't do it out of fear. They don't do it because they were ordered. Do you want to know what the number one reason is? For the guy in the foxhole next to them. Creating, quote, the social network. But the shame, the fear, the guilt that I need to do this for other folks. I didn't use it today, but we have a device in the lab that uses guilt to motivate you to take your meds. Because if you don't take your meds, a toy that is given to your grandchild will die if you don't take your medication. Now you tell me, what's more powerful? A phone call saying, Joseph, did you take your asthma medication? A widget on my belt that says, oh, time to take your inhaler, or a grandchild calling me, Grandpa, why is my pet dying? I think the 9-year-old granddaughter calls are a lot more powerful. Another question?
We do have time for one more question.
I'm hearing voices again. Okay.
Your questions are important. There are microphones in the front if you want to be heard by everybody. Thank you.
Great. You guys are hearing voices too, right? Okay. One more question I heard. Yes.
So I worry a lot about the part of the population who is not so capable, who is perhaps not as well educated, are not along the trajectory of technology as quickly as others, and who perhaps have disparities in the way their care and everything else has been delivered to them.
Yeah, we've gone now from the challenge of health literacy to health numeracy to technology literacy and usability questions. But I'm going to suggest something to you that may be somewhat provocative, to use the word that Bob promised, and that is that I don't think it's just for those either of lower income, education, or physical well-being. There's a lot of folks in this room who can't balance a checkbook, but you're really smart at what you do in other areas. That the technologies we have out there and the models of behavior that we're asking people to perform have got to be made so simple, so transparent, and by the way, so reinforced as a narrative of how we live our lives that yes, the PhD, MD neurologist can do it, but so can the guy that cleans his office at night. So I'm not sure that by focusing in on one segment is the answer, but frankly, we should create products, services, and solutions, be they technology-enabled or others, that are easy for everyone. The reason why you all raised your hand with the iPad, I'm not here speaking for Apple, is because it's fun, it's easy, and I don't have to tell you that I'm over 50 and that's why I have to raise the font size large. It just makes it possible so that for those of us who are blind can see it and those of us who can see smaller font can do it. So yes, I think it's an absolute issue. The digital divide issue has started to go away, but the usability and the way that we're asking people to live to be profoundly rational in a world that reinforces the irrational is going to be the great challenge. Thank you very much. It's been a delight, Tracy.
Thank you, Joe. That was an incredible presentation. Please join me in thanking Healthways for their sponsorship of this morning's plenary session, and also for thanking Jaan and Fred for joining us as well. We will now launch the first in our presentations as part of our juried award format. Please find your way to one of the outstanding nominations in the concurrent session tracks being held on this floor and up on the third floor. And we will see you at 11:45 in the Network and Solution Zone for lunch. Thank you.
Ladies and gentlemen, please